Welcome to this afternoon session. Okay, sounds like there's still energy in the room after lunch, so that's great. So we're heading into our plenary panel, our part 2, but I just wanted to do a couple of housekeeping points first. The first is that a few of you have been asking about the photographs that we had taken last night. You probably saw Martin wandering around with his camera, and I know that he took photographs of some of you on request, standing by your poster and so on. So we'll need to find out a way of making some of those photographs available to you. We'll put some of them on the website, just so that you can see the kind of photos from the conference. But if you want copies for yourself, we'll have to figure out the logistics of doing that, because there'll be a lot of photos, and he's also coming tomorrow morning. So just to say that we've noted your interest in that, and we'll figure out something. The other thing that I mentioned this morning was your interest in having a mailing list of participants at the conference. I talked to our conference organizers, and apparently this will be a surprise probably to most of you, but when you registered, you ticked the box saying you agreed to the terms and conditions, and in there was that we could make your mailing information, your contact information available. So we are going to go ahead and do that. And if you now realize that that was an error on your part, you better let us know very quick. Otherwise, we think we have your permission to circulate the contact information for us all. And then lastly, just a reminder that this is a scent-free environment, and we have people with various allergies, so please respect that. And also that I know some of you have left coats and bags outside. Please don't leave anything valuable, because we can't guarantee that they're not going to disappear, unfortunately. So please be responsible for any valuable items that you have. If you leave cell phones behind on the table, which a few of you have done, we do sort of have a unofficial lost property office at the registration desk. So I'm moving on to our panel. You will recognize some of the same faces from this morning, Jools and Annie, but also we brought in a couple of new folks, Matt and Gabby. Matt, you're the next generation, so,
Looks like it, right?
Yeah. So we think that you'll have something important to say about the future. The format is the same as this morning, so our panelists, including Lynn, who will be on the video, will say a few remarks about what they see as future opportunities and some of the things that perhaps we need to be aware of. And then we will open it up to the floor to get your reflections or projections, I guess, into the next 10 years, and what you would like to see and the opportunities. And again, we are recording this session, so not only us can refer to that, but we'll also make it available to people who can't be here. So, I think we got you first on the list, Matt.
No pressure. Good afternoon. I'll briefly introduce myself. My name is Matthijs. I have a background in medicine. I'm a medical doctor, and I started my journey in patient and public involvement in education about 10 years ago when I was a medical student myself. So I could have also been on the first panel, so I don't know how much I am for the future generation. But yeah, I have my notes on this thing called my smartphone, whereas I see people around me still using pen and paper. So that is actually the first thing I want to talk about. and that is the world around us is developing at an unprecedented pace, and especially technologically. And these technological advancements may also put the ability to make a human connection under pressure. And I think that also provides a rationale for all the things that we're doing here, like the patient and public involvement in education, so important. Many people may be scared for these advancements, but I think we can really use them to leverage the importance of the work that we do to senior leadership. And they can, serve as a case for meaningful patient involvement. What I've noticed along the years is that there's a lot of appreciation for the patient story. And I'm very happy to see that there were some early adopters also here on the panel who really moved that appreciation to integration into their daily work, but also in their governance. They have dedicated departments where really the patient care community, also at your university, is part of the work of the academy. But I think that that's not everywhere the case, and that's why a way forward for me would also be that we have to move patient and public involvement from a nice to have to a must have. Because everyone in this room knows that it answers everything an academic institution should do. It makes transformative learning experiences possible, but not only that, it also makes sure that we can do responsive research, and it can also help us make meaningful person-centered care if we involve patients in quality projects. And that will be my next way forward. To not only think about education, I think it's a good start, because that's where the future healthcare professionals are born and bred. But again, to use a lever for institutional and senior leadership, we can move to adjacent fields, such as research, and such as healthcare and quality improvement projects. As I think oftentimes many ideas are still conceptualized by people like me, medical doctors, and then only after a certain amount of time consulting patient involvement or patients, saying, hey, what do you think about this? And that's too late, I would say. The last thing, and it's, I think, an elephant in a room that might not have been addressed yet. It's about remuneration and about payment of patient involvement. I think it's a tricky subject for everyone. And I want to raise the case, or at least start the conversation on leaving a transactional way, or maybe adding to a transactional way of remuneration, so that the hours you've worked you get paid for, but also think of remuneration in a way where we can organize reciprocity for patient partners. Because if we ask everyone in this room, the patient partners in this room, I think there are a lot of people, even without payment, are doing this or will be doing this because there's so much more to it. And how can we, as institutions, foster this connection between people, the development of people, even help them get to jobs again? That is something that we really need to think about in the way we organize, because if we don't do it at the beginning, we're too late when we've organized it already. So if you're at the starting point, please think about how are we going to organize this reciprocity for patient partners.
Thank you, Matt. Annie, do you want to?
Yes. So yes, the remuneration is a big question, and is going to remain for the next 10 years, I believe. For me, the challenge for the next 10 years is the question I ask myself is, when patient partnership is no longer a new and innovation project, how is it going to turn out? So 10 years ago, it was a pilot project, and today, from what I've seen in the last 2 days, it's no longer just innovation. It's almost more and more a common practice. So how are we going to move from program level enthusiasm and people who are enthusiastic about it to a very strong institutional infrastructure? And how are we going to move on to the next generation when our pioneers are leaving? I know I had my mentor leave last year and I was devastated because I thought, oh my God, this is never going to survive the pioneers of these of patient partnership. It does survive. But how can we make sure that we move on with a structured institutional level? On our side at University of Montreal, I guess we need to invest more. We've been really invested in interprofessional education as well as the medical program, but we need to expand to other areas of the university, which seems to be surprising to them as much as it is to you, because the relationship is not well established in other programs so strongly as it is with interprofessional and medical programs. So that's, and CPD, for example, like how can we develop better CPD participation from patient partnership. The other challenge that I see is that we at University of Montreal have very growing cohorts, like more and more students. How do we manage expansion of patient partnership within, and without it being like just getting bigger and bigger, and without diluting the reflection around patient partnership? I think one of the other challenges that comes with it is when you're doing the logistic of integrating patient partnership, there's a danger of losing the reflection that comes along with it. And we are at risk of reproducing whatever we don't like in the system, in the healthcare system. So we need to be very mindful of not reproducing schemas of behavior that we don't like, that would insinuate itself in our daily practice. So I think we need to be really mindful of that pitfall, and that's a challenge. And I think also that the way we recruit, like a diversified recruitment, would be a prevention against reproducing silos and reproducing behaviors that we do not agree with as patients in the healthcare system. Also, another point was, the training of patient partnership, the training of patient partners. Like we want to make sure that our community of patients can follow the evolution of teaching practices. We don't train the same way we were training them 10 years ago. So how can we keep up with the training needs? How can we keep up with making sure that we stay connected to the changes in the practices? We need to make sure we stay connected to the new cohort of students. The students of today are not the same students as they were 10 years ago, so we need to adjust our own discourse. So how do we make sure that we keep up with that? Strangely enough, another challenge I see is that we are all connected here today in this great conference, and we have many, many ways of staying connected, but somehow it is a challenge to stay connected. And the more we're doing this patient partnership worldwide, I think the more we need to stay connected to make sure that we are aware of what everybody else is doing and which direction the whole movement is taking. And so this type of conference needs to happen more often.
Thank you for volunteering, Matt. Okay, Jools.
So I've had a costume change and sat to the other side just to, mix it up a little bit. I'd echo what you've both said, but what I thought about when you were talking about technology and, how do we train the patients and carers to stay up to date, I would say that at Leeds we've had great opportunities because I don't know if people have heard of the British Medical Journal. It's one of those kind of institutes where you have to curtsy if you mention it. I was asked about 10 years ago to get involved, judging teaching competitions, etc., etc. And then recently, 2 years ago, actually, I was asked to get on board with a new work stream that their output around future healthcare, and that's all around technology. And so I said, I don't know anything about it. I'm an absolute Luddite when it comes to technology. I have not got a clue. And they went, you're exactly the sort of person we want. So I went along, and 2 years on, I don't think I could live without generative AI now. And the patient carer community have been involved. I came straight off the back of the conference in London over here, hence being very, very tired. However, we were part of running the conference for the British Medical Journal, so the power balance had shifted somewhat there, and we reflected on what it's like back at the university with our undergraduate medical students, and we realised that the patient carer community are more highly trained in technology than any of our other tutors, clinicians, and our students. And I didn't think that would ever happen. I would think we're always trailing behind. So the patients are now teaching the students about technology, which is just fantastic. One of the big challenges for me, and I think I've really got it stuck in my head, I'm struggling to get it back out again. I'm hearing it mentioned around the place. I think in the UK we're going through a difficult time as universities with funding. We've had international student caps, so our funding is quite low. They don't want to put the tuition fees up. They want to get more students in, pack them in. We're at breaking point, I think. We're creaking. And what I find very frustrating is, I remember years back, possibly just after the 2005 conference, going back and having a really enthusiastic professor in the university who kind of did that real doctor, don't know what it is, prove it to me and I'll back you thing, which I just love. I don't want the smiling assassin. I want someone to just tell me straight, you perform, you get me the goods, and I'll back you. And that's what she did. And that helped all the things we have today take off at the university. I've been there 24 years now. That professor unfortunately retired some years ago, and we've had possibly 5 cycles of senior management. And the sad thing is that really gets me down is you get new senior management and you are like going back to minus square one again. And it's like, how can this be happening all over again? We've been here, we're embedded, we're established, but you don't get it. And I'm sick and tired of having those conversations. And I'm back to that again. And we're having a new curriculum launch in 2 years' time. And I seem to have gone through the same cycle. And what I got thinking about was, it's bigger than me, it's bigger than the university. In the UK, we really need our governing bodies to get behind what we're doing. I was listening, Australia, wherever you are, if you can, there you are. If you can get the General Medical Counselling and the Nursing and Midwifery Council on board, and they talk about you have to have it. You have to have patient or service user involvement. We know that. Then they come and check up on you to see if you're good enough. And I say, what is good involvement? Oh, we don't know what good involvement is. So how are you grading me on what is good involvement if you don't actually know what it is? So I think there's a lot of words and a lot of lip service from the governing bodies, but they're not giving us enough backing. So if they were to say, you have to do it, and these are the standards, and here's some best practice, and here's some amazing case studies, then I would think within our own institutions, the senior management would take it more seriously, because it has to be done. We can't rely on enthusiastic people to keep it going. Somewhere, someone along the line says, this has to happen, or we shut you down.
Okay, thank you. Pass the mic to Gabby.
Thanks, Jules. So my name is Gabby Brand. I am from Australia, so I can speak to a little bit about that. I'm from Monash University, which is a really large university in Melbourne, Australia, and our faculty is huge. It teaches about 14 disciplines. I lead the education research within our school. I'm a proud nurse, but probably we'll be talking a little bit more from a researcher perspective, because leading the education research and thinking about co-designing education with consumers is what we've been doing at Monash. I am really passionate about translating research into education, but also challenging some of the ways we view impact, which I think is really, really important. So thinking about, and although Australia has started to embed in the accreditation standards and some of the standards of the different health professionals about working with consumers and community, it's still a little bit ambiguous. And I think one of the things that we really need to focus on is changing the mindset of health professionals. I mean, as a nurse and training nurses and also other health professions, I know we're still training through a very deficit lens. We're focused on problems and diagnoses and diseases, and we forget that there's a person, and we need to think about that holistic person. And so, we're trying slowly to push against the mainstream of, scientific sort of clinical skills and focusing on, producing functionary technicians rather than humanistic practitioners that see the person. And there are still some huge institutional barriers, which I've heard as well, like remuneration and paying participants. And one of the main things we're finding in Australia is around funding. So when we get funding to do some research and working with consumers and community, there's very short time frames, and as a researcher that's really difficult to meet those time frames because of the time it takes to build trusting relationships with people and communities. And so they just want the outputs, and I'm there saying, but actually this is a process, and the learning happens together through the process, and for it to be meaningful, we need to have the time and the space to be able to do it. So one of the things that we're doing at Monash was I led a fellowship across our faculty to build capacity with educators to co-design and work with more patients and communities. And I think, and that was only because there was one professor who, like you said, believed that this was a good thing but didn't know why it was good. And so one of the things that we did was just work on different pilot projects across paramedicine, anatomical education and all those things to work with educators who are interested in, and worked with them and walked them through the process. And after that, a couple of years of doing the process as well as publishing, so as an educational researcher, showing them how to publish the research so we can build the evidence and the impact out there, then they came to us and said, well, we don't want to work with people any other way. We don't want to do research any other way. So it was almost like we needed to spend that time and walking alongside them to show them how that can be done. And I think that's the culture shift that we need, and the unlearning that we need as academics and health professionals of unlearning how to do it and learn it in a new way.
Thank you. And James, can we show the video of Lynn so we can have the final panelist comments?
Hello, everyone. For those who didn't see me in the previous panel discussion, my name is Lynn Ashdown, a patient partner who initially trained in medicine and went from full-time resident physician to a medically complex patient after sustaining life-altering injuries. Since entering the patient partner and healthcare professional education realm, I have seen many changes, and I'm so excited for what the next 10 years will bring. One area that I believe will flourish over the next decade is the thirst for connection and collaboration between healthcare professional educators, institutions, and patient partners. While I am a patient partner in various roles, I'm currently patient partner lead advisor to the Association of Faculties of Medicine of Canada, or AFMC. And just a few months ago, a patient partner network was established in collaboration with the AFMC. By partnering with the AFMC, this network not only legitimizes the role of patients in healthcare professional education, it represents a community through which an eclectic group of stakeholders, including patient partners, can connect and share knowledge, exchange ideas, and guide future standards. This network is also a way in which senior leadership at educational institutions will become aware of this important work. I anticipate tremendous growth in this network and hope that other high-profile organizations will follow suit. While the presence of patients within healthcare professional education, even if it's simply through sharing their lived experience expertise with learners, has become normalized, patient partners' presence in other aspects of curriculum is still largely absent. I believe the next 10 years will see the inclusion of patient partners as assessors in healthcare professional education. If patient-centered care is viewed as the gold standard in healthcare, partnering with patients as stakeholders in assessment helps to advance this cause. In light of changing healthcare professional education practices, such as an emphasis on competency-based education and multi-source feedback, programs will be reviewing their assessment policies. These changing practices represent an opportunity to incorporate patient assessors as a legitimate source of data for learner feedback. While this will ultimately be beneficial for learners and ultimately patients, this won't be an easy task. Recognizing tensions and resistance amongst historically the most powerful stakeholders in assessment, for the most part clinicians, will be a key step towards this change and innovation. This will require deliberate dissemination of the benefits of including patient assessors in healthcare professional education. Additionally, incorporating patients as assessors will require the creation of new assessment instruments using plain language terminology co-designed with patients in order to facilitate and optimize the capture of useful feedback, articulate student learning needs by patients, and advance the role of patient assessors in healthcare professional education. Lastly, I believe the next decade will start to see the inclusion of patients in healthcare professional education as accreditation requirements. This is because accreditation is enhanced when it incorporates the interests of the people who are served by the healthcare system, ultimately the patients. This would see the inclusion of patients as partners in governance, curriculum design, teaching, and assessment as requirements for accreditation. We all know accreditation is a powerful tool to drive change, and including patients in curriculum as part of accreditation requirements will help to improve the social accountability mandate that institutions have, enhance the relevance and responsiveness of educational institutions, and strengthen professional identity and empathy in learners. As most of you attending this panel discussion will know, there's already a lot of grassroots efforts to include patients in healthcare professional education. However, senior leadership is often unaware of these efforts and processes already in place. That's another benefit of having patient inclusion as accreditation requirements. It will get the attention of senior leadership who are ultimately in the most powerful position to influence change. Changes to accreditation are difficult, time-consuming, and requires tremendous advocacy. So, this won't be an easy feat. However, this has the potential to yield exponential change in the patient inclusion of healthcare professional education landscape. I'm excited for the next 10 years. Are you?
Okay, thank you. So it's time for you folks to come and give your thoughts to the microphone. And while you're doing that, is there any further comments from the panel at this stage? No? Okay, Hugh, I think it's you.
It is, thank you. I'm Hugh Alley. I'm a patient partner based in Burnaby, BC. My background's industrial engineering. I work in the world of making plants and facilities run better. It's been really, and this is totally new to me, so it's been really fun to listen to what you are working on. I see two issues that I haven't heard anyone talk about, and I think they are going to be challenges for the idea of having patient partners over the next 10 years. The first is that this conference seems to be focused, as I have seen it, on the training of new clinicians. And that's great, but there's this great elephant of existing clinicians that are out there, and they're not getting what you're doing in the universities. And I wonder if what needs to happen so that patient-partner interactions in any of the many ways that we've heard about can be a legitimate continuing professional education for clinicians. And so that would be one challenge, is how do you move this stuff out into the, every year you got to do 10 hours of patient-partner related stuff or something like that. So that's one. The other is what I would see as an unstated hypothesis, and it may be that I'm just new and don't understand the background. But the hypothesis is that if there are patient partners involved, then the physicians will actually do better in some way. But what does better mean? And is that in any way validated by outcomes? And I haven't heard in the places that I've been today and yesterday, haven't heard anything about the actual health outcomes of us as patients. You know, so my doctors had that training. Am I going to live any better? Or is this just feel nice? And I think this issue of how do you evaluate, how do you show that there is benefit is going to be critical to getting the funding. And in the end, I think you need to be able to show that it actually pays, that somehow health costs, the costs of sickness in our society are less when patient partners are part of the training of clinicians. I think that's a reasonable hypothesis, but I haven't heard the evidence in the sessions I've been at, and so I would suggest that that's a huge hurdle that you need to deal with in the next 10 years.
Thank you, Hugh. So just in case everybody was thinking we got it sorted out, Hugh has posed some difficult questions. Bram, and then we'll go on the other side again.
Yeah, in 10 years' time, I would like to see us doing this work as a sports, as a team sport. So many of us have produced podcasts, resources, and everything, but we may not have enough funding to see it through. We may not have enough opportunities. We may not have big enough sample to pilot it and to test it and to build evidence around it. Toss it around. Toss it around to others. Let's do it together. So why should I create something from scratch when there's already something that I can use, and then I can run it with my students and then contribute to the impact of what you do to test it in other settings, other professions, other parts of the world. Let's just keep tossing it to one another. When my funding runs out, I'm going to toss it to who has funding for this, who has opportunity, who wants to do a PhD on this. I'll toss it to you. You do a research on that so that you will continue what I do. You build on what I do. And then toss it back to me when I have other opportunities, and so on and so forth. I believe we can amplify one another's work if we do this as a team sport. Thank you.
Thanks, Bram. Yes, please.
I'm Chris from Vancouver. I'm a patient partner. my main patient partner experience has been on the on the health services side and a little bit on research. So I'm just entering this. And so I want to reinforce the idea of connecting the different patient partner roles, because there is, in our minds as patient partners, there is potential overlap. And that relates in part to continuing education aspects. When I'm supporting people with a project, it may be helping the health professionals with their care pathways. It may be helping them with setting up advanced care approaches. It may be actually redoing websites. It's all educational, and that's my frame of reference. So I think connecting these, as has been suggested by a few people, including Matt, I think will be important. The last thing, the most powerful stories that I have encountered in the groups have been from the care support people, caregivers, however you want to say it. And I know patients, you said right at the start, was, for everybody, we're using that term. But I'll just sort of reinforce that caregiver stories are extremely powerful. And they're often women. So they will resonate because they are our mothers and our grandmothers. And that will really resonate with the students. So really think about how you're going to involve caregivers as well. Thanks.
Thank you. Darren, this sounds like an opening for some of your interests.
It's reflection, actually. There's two pieces here. So first, thank you all for your words. It stimulated my brain to think about some things. So the first comment is, as Gabby pointed out, the researchers, the patients are beginning the marriage to walk side by side. It's fabulous. But we have that third person in the bed, and that's our institutes. Our institutes are geared tenure, publish, or perish. Somehow we have to change that little concept. Not sure how, but it's a barrier for us all to do good work together, because sometimes our relationships take years to come to fruition. From my Indigenous friends and colleagues, they tell me, Darren, 10 cups of tea. Before we will talk about this, we need to know one another. So that doesn't fit an institute's timeline. Moving along, I've been hearing AI, and yes, AI is coming. But I attended a conference where we spoke about AI and in the bigger picture of risk. As we publish with patients, we now need to start thinking of risk, because we know there are alternative facts out there, alternative viewpoints that don't like us, that are in the scientific world. And so what are we going to do to protect ourselves on our emails, our Twitter accounts, our YouTubes, all of that? So I leave that as a question going forward in the next 10 years. We're going to have to really think about that part.
Yeah. Thanks, Darren.
Can I talk a little bit to that one, Angela?
Yes, of course.
Just in terms of the research, I totally agree. I mean, there is a substantial clash of values between everyone, and it's about having these times to be able to sit and talk with each other and understand each other and come up with a shared understanding. In relation to the funding issue and the evidence around how this work that we're all doing is actually impacting on patient outcomes, I mean, that's the holy grail of education research. And unfortunately, in Australia and probably globally, we're still favouring those scientific randomised control trials and those types of things, and all the money goes to science and lab work, and very little goes to the education. So thinking in the next 10 years to be really strategic about how we leverage some of that research. And in Australia, the big funding bodies that fund medical research have said now they need consumer and community involvement, and unfortunately all the researchers that don't tend to get it are ticking the box and getting consumers on at the last minute. They're not there from the beginning of framing the problem or anything like that. But, you know, as a methodologist and as a health professional, as an educator, getting on those particular grants and saying, how can we actually focus and leverage that money, get a pool of that money to translate that into education and to show that we need to have a wider impact. So at least we're sort of bridging some of that clash of values, but there's still a lot of work to be done in that area.
Thanks.
And on that note, thinking about that, and someone mentioned validation and revalidation. I think if the people with the grant money and the research money had patients and carers working with them, there'd be a change, because I remember being asked by the Nursing and Midwifery Council to go on their assessment team for revalidating courses within the UK. And I went to a university that were teaching nursing students, and it was being revalidated. And the group said, so can you tell me what you're doing in terms of involving service users on your program? And they said, oh, we're doing loads of things, and we're doing this, this, and this, and this, and this. And they were like, oh my God, that's amazing, that's amazing. And I went, but do you understand any of that? And they went, but no, it sounds really good. So I asked the question, they'd got all the service users there lined up, every size, shape and colour to tick those boxes. And I said, well, so could you explain a little bit about what you do? Because it was my area of expertise. Well, it was like pulling the pin out of a hand grenade and lobbing it. Honestly, it was like, why would you ask that? But if you don't have people with that experience on those revalidating panels, you can tick your box really, really easy. For the grant money, have you involved patients? Yeah, we asked them at the end of what they thought of it, and it was so above their heads, they just went, yeah, fine, put my name on it. And revalidation. Oh, we're doing patient involvement. Oh, well, look, we've got all our patients here. But what exactly are you doing? And then it's like, oh, right, okay. Again, it goes back to if we have patients and carers within our governing bodies, within the people who issue the grants, within research, that say, yes, you can have that money, then it's much more authentic and genuine, and people are not getting away with ticking the boxes, but we are not there yet.
Thank you. Connie.
Hi, I spoke earlier, but I'm from BCIT, Institute of Technology, and one of the pieces I'm looking forward to is, I know COVID kind of had some disadvantages, but one of the advantages was moving into that virtual world. And our institution has a provincial mandate, and so some of our committees have members, our partners from all over the province. And so I think that's really allowed us to have more of a diversity of perspectives. And so I think moving forward that, hopefully we can lean into that and have, I've met so many wonderful people. I'm wondering if this is going to be a community of practice and that we can, chat on a regular basis. And I think that the geographic distances aren't going to be as wide as they were before. So I think the next 10 years, we can do some great things.
Thank you, Connie. Carolyn.
Hi, I'm Carolyn Canfield, and I work through UBC and a lot of other places, but based here in Vancouver. I've got a couple of dilemmas, and I guess these are areas that we need to keep mindful about and think about how to create appropriate structures and supports. One is, this reference to funding, and people have heard me talk about this before, that the funding structures for patient and community involvement in education, for research with community partnership, for much else, is the structure is and the schedule is antithetical to relationship building. And I think we really need to do something, and I don't have answers, and I think all of us can contribute to imagining answers of how to support in a tangible way the development of relationships. I mean, Darren talked about the 10 cups of tea. Who pays for that time that may be stretched over years? How do we continue after the end of a project in order to maintain the relationships that are continuous and to support the commitment that we have to each other? Communities of practice work well when people have other forms of funding, other forms of support. But at this point, we're still in a pioneer phase, I think, of this. So that's one area. It's kind of a structural challenge. On the other side, rather than, I've got sort of two more points to make. One is recognizing the diversity of the character of patient partnership and community partnership. And I'm thinking more of individuals, caregivers and patients. Not everybody commits full-time. Very few people have that capacity. Helps if there's a salary, if there's a way to make a living doing this, and there are few patient partners who do have job descriptions and employment. Even that is qualified by health. Many patients actually are patients. Many people are managing health conditions that can encroach on their productivity in a partnership arrangement. So I think that's sort of the most extreme level of having full-time committed patient partners within an organization, within a project. And they're all the gradations. It's a partnership that's full-time for 3 months or 3 years. There's a partnership that's part-time for 2 months for 7 years. And then people can't predict their health. They can't project ahead to make the commitments that oftentimes projects depend on. So there may be a couple of lead patient partners in a project, and if they drop out 5 years in, 5 months in, it may be devastating for the project. So the assumptions of reliability in a kind of project management standpoint can't be made. There are other kinds of demands that are on patient partners, especially when it's not a part of a career. So I think trying to, as we project into the future, trying to build models of support where the support is continuous, whether a patient is actively involved or a community is actively involved at the moment in a project as a partner, or whether they're in a recovery, a liaison, I need a break, I'm doing something else, I have a job that I need to work on, I have a business that needs my attention, I have a family that has demands, and being able to take a break out. So the way we imagine partnership careers and how can we incorporate a kind of continuous support that makes available opportunities for people who are interested, but also doesn't demand participation only if you can make it a career. And a few years ago, that we used to talk about professional patients. I think we've learned that that's not a very useful phrase.
Thank you, Carolyn. One last point, Prachi, and then I'm going to have to make a few final remarks.
Yeah, thank you. Really enriching discussions the last 2 days, and I want to begin by sort of contextualizing where I'm coming from to the HPUE world. I'm a person with lived experience as a patient and as a young caregiver, do clinical research or professionally speaking, but I also facilitate interprofessional education through CASH at the University of Toronto and as a TA at Dalhousie. And one of the pieces that I'm sort of left wondering about is, is a point that folks have alluded to so far, which is relationships. And I don't know how much trust there is in the institution from the public. And in my session yesterday, I sort of shared with the group that I don't think my parents would ever show up to an engagement, right? So I hope what we can sort of, I guess, spend some time pondering about is trust. And how do we build that trust? In a lot of contexts, we're starting from the ground up. Those relationships have never existed. And, I I strongly feel that that's a gap that needs to be addressed in order to bring in more people into this world, but also at the same time find ways for healthcare culture to change. So just want to bring that point up and sort of.
Thanks very much, Prachi. And I think that leads into a couple of things that I want to say in wrapping up. First of all, if you have ideas that we haven't touched on, the message board at the back, and there's paper on your table, so you can put up anything that you think that we've missed that we want to add into the mix. The other thing is, earlier this morning I said that tomorrow we're going to be doing some work on some practical guides, and I know there's going to be a roundtable discussion on compensation for patient partners, another one on ethics of patient partnerships. So if you're interested, then obviously available. There's going to be lots of great discussions tomorrow. But if you're not available because you've got to get a flight home, again, if you're interested in any of these topics, put something on the message board. There's paper and pens on your table. You can write down your name. I'm interested in, and we can follow up with you later. So please don't feel that if you can't be here tomorrow, you've lost the opportunity. And lastly, I'd like to do something that we haven't really thought through really very well, but this is, impromptu as the ideas come forward. And one of the things that, we've touched on in this last hour is the idea of, whose voices are being heard, or whose voices do we need to start bringing in? And what do we mean by, providing flexible opportunities for people to participate and so on. And, I'd like to add in another, so that there are sort of new people that we need to engage with. And we're seeing at this conference new countries that are beginning to really do some innovative work. And, we're from the old world, if you like, but I've been really excited by the fact that we have people here from South America, for example, which, we didn't have before. And I've been really struck by the work, and I'm going to call them out, that Milena and Valdemar have been doing in Brazil. If you haven't heard about their work, they're working with populations that are among the most vulnerable and living in very dangerous situations, and bringing them into educating health professional students is a hugely difficult task. And I think that they need all of the encouragement that they can get from people like us. And so I would like to give them, we haven't got a formal award, but we'll think of something. And I would like to suggest that all of us give them a round of applause and come up. And the best award we can give you at this conference is a hug. And it means a lot to them to be able to come to this conference and to make connections with us. And so I don't know what we're going to give you, but we'll send you a T-shirt and a bag. So, and we'll send you some kind of certificate that recognizes the pioneering work that you do from this conference. So thank you. And if you haven't had a chance to connect up with them, they're going to be around for the conference, so find out some of the really interesting and pioneering work that they're doing, which we can all learn from. How do you bring in the people who don't have any trust with the institutions and would not feel comfortable in the institutions, and how do we go into their territories and work with the community? So thank you all for participating in this, looking forward the next 10 years, and we will be looking forward to seeing you tomorrow. Otherwise, we've got 2 more concurrent sessions, one immediately now, and then there'll be a coffee break, and then our final session of the afternoon. So thank you very much.